and welcome everyone to another episode of Talk with a Doc. My name is Janvi, and throughout this series I will be talking to doctors of different specialities and those at different stages of their medical journeys to learn more about the variety of opportunities within medicine. In today's episode of Talk with a Doc, I am going to be talking to Dr Ravikrishna Mamidanna, an upper GI and bariatric surgeon working in London. Thank you so much, Dr. Ravi, for spending some time to talk with me today. I'm really grateful for this opportunity. To begin with, could you just tell me a little bit about your speciality and what your job actually entails?
Sure, it's my pleasure to be here. I'm a general surgeon. So we basically deal with all sorts of general surgical problems. But I've also specialized in the upper gastrointestinal tract. So that involves the esophagus, the food pipe, the stomach, the small intestine, and the gallbladder. And in particular, I've specialized in bariatric and metabolic surgery, which in layman terms is essentially weight loss surgery. That we offer for patients with medical problems associated with being overweight.
Sounds really interesting and a very unique line of surgery. What enticed you into entering this speciality?
So I was always interested in a surgical specialty.
Okay.
I knew from before that I wanted to do surgery. And then once you get into higher surgical training, you're exposed to different subspecialties as part of your rotation. And that gives you an opportunity to have a taster of each subspecialty and see
Okay.
what excites you. So was something quite interesting for me. Metabolic surgery or bariatric surgery is something that's evolving. It's being taken up all over the world currently. And there is good enough evidence to show that a lot of medical problems that are associated with obesity can be cured or reversed. So that led me to choose this subspecialty.
That sounds really interesting. And you said there's lots of progress being made in this subspecialty, and it's obviously very important to the Western side of the world. What would your typical day in a life look like? Is it mainly elective surgeries, or do you also have some emergency surgeries as well?
So I do a mix of both. So one in every 6 weekdays and one in every 6 weekends, I'm on call for emergencies, which are related to any general surgery.
Oh, I see.
And in my elective or planned operating list, it's usually bariatric operations, along with general surgical operations, such as operations on the gallbladder for gallstones and various types of hernias and things like that.
Oh, okay, I see. What interested you in specializing in surgery in the first place? Why? Because you said you knew from the beginning that surgery was more interesting for you. What fascinated you about that line of medicine?
So during the first year in medical college, we are exposed to anatomy dissection. Doing a cadaveric dissection, trying to understand the intricacies of the human body and the very, very complex nature of all the organs and the organ systems, it led me to wonder that surgery would give me the tool to try and unpick problems associated with what we call as normal, and then to try and fix them in a way that you would service a car or repair a computer. You take parts apart, do what's needed, fix the one that's not working or faulty, and then put them all back together. So that was very interesting and fascinating to be able to do that on a human being and to change their life. So that's what interested me.
Definitely sounds like a lot of fun. It sounds like a problem-solving game as to how you're able to, piece together the human body, which is so detailed and so there's so much to discover. That definitely sounds very, very interesting. What do you like most about your speciality? You said that you are a general surgeon as well as subspecializing in bariatric surgery. That must cover lots of different things. So, what are some of your favorite aspects of your job?
So majority of my practice would be taken up by bariatrics, and the interesting part or the reason that I do enjoy my job is the fact that there are so many medical problems that are associated with being overweight. Currently, we all know that there is a social stigma associated with being overweight. So to be able to help these patients, to be able to perform surgery in order to help them lose weight, And it's not purely the weight loss. There are what we call as metabolic effects. So you can bring about an absolute change in the quality of life of the patient. There are patients where we've cured high blood pressure,
Oh,
cured
wow.
diabetes, improved their mobility, got rid of their joint pains. So it's life altering, and it's very satisfying when you see them having lost, about 50 to 60% of their excess weight, come back to the clinic in a year or 18 months time as a completely different person, not just in the physical appearance, but also in the way they are able to conduct their day-to-day life. That's very satisfying.
Definitely sounds like surgery as a whole definitely sounds like a very satisfying line because you're able to see instant results as after you've done your surgery. And also, it sounds really interesting that being a bariatric surgeon isn't just about the cosmetic effects, but it actually has real medicinal advantages, and you can see that in the patients. That does sound very, very useful. And you talked about the idea of the social stigma around patients. Would you have to communicate with patients before and after the surgery? And what is that like? Because as you said, obviously it could be quite a sensitive matter discussing their, obesity or not. So what is that like?
So the way the system works in the UK is that the patient first has a chat with their own GP, who would trial normal interventions in the community, such as advising them about diet and exercise. It's majority of these patients are not overweight just because they eat too much. There are metabolic problems associated with it, and those are the things that need to be addressed. So when they come to see me in the clinic for the first time, they are already aware that the main problem is the weight they are carrying, and they come to me seeking an alternative way to lose that weight. So obviously, it's not as easy as just performing the operation. That's my job done, but the job of the patient begins then. They have to have a very strict and disciplined dietary and lifestyle that they have to follow after surgery. So they get almost a year of training before the surgery
Oh,
itself.
right.
See them regularly. Just not myself, it's a team effort. I can't take all the credit. So we have dietitians, we have psychologists, we have specialist nurses who deal with the patients, very frequently, every 6 weeks, 8 weeks, keep an eye on them, keep advising them. And once they are geared up, once they're ready for the surgery, that's when we do that. We are basically providing them with a tool that would help them achieve weight loss. And it's up to them how they use the tool. So that's what the training is all about. Even after the surgery, for the rest of their life, they have to have a disciplined approach to their eating. They have to have a disciplined approach to their exercise. So watch on what's calories that are going in, how the calories are going out in terms of how much exercise they do and things like that. So there's a lot of preparation that goes into it, even from the patient side.
Of course, yes. It's not just as simple as going in there and fixing the problem. It's a huge multidisciplinary team behind them supporting each patient, which is really great to hear about the whole holistic care that we're always taught about at school. Because you talked about the idea that most of your surgeries are usually elective surgeries because it's to do with the patient and how to help them with their weight loss, and that's something that can be planned and thought about. Did the pandemic affect your practice by a lot? Because obviously, it was much more stressful times in the hospital and emergency cases were piling up quite quickly. So did that shift the focus during the last year or so?
Oh, it definitely did.
Okay.
The NHS, as we know, was overwhelmed with the pandemic, especially in the first wave. So they had to divert all sorts of resources, whether that was manpower, whether that was hospital beds, whether intensive care beds. So there was no way that we were able to undertake elective surgery.
Right.
There wouldn't be enough space in the system to do that. So all of these operations were put on hold. And the manpower was diverted towards intensive care and respiratory wards. There was no way we could undertake a lot of our clinics either. So
Right.
some of the patients were obviously left high and dry. But we tried to continue with some telephone clinics, keep moral support going on. There were reports in the papers that obesity itself was one of the bad factors for outcomes from COVID infection. So obviously a lot of our patients were in fear. So we had to address all of that. And then as slowly the services started to resume, there was an article from the Prime Minister, Boris Johnson himself, that they realized that obesity was one of the factors that needed to be targeted.
Mhm.
So we undertook elective surgery quite rapidly. We had green pathways and had all the setup in place to perform these surgeries to try and reduce the burden of obesity and hence indirectly reduce the effect of COVID infection itself on these patients.
Right. Okay. So it did have to put a delay to quite a few patients, and of course, because as you said, like it takes a year before and after to properly plan this surgery and make sure that their life after the surgery is also at a good level. So of course, by shifting that because of the pandemic, it must have maybe derailed their motivation as well to keep going with this schedule and keep trying to achieve the sort of requirements for being able to get this surgery. So what other sort of surgeries did take its place? I mean, obviously, COVID has had a lot of news on respiratory and other sorts of responses from the body. So what sorts of surgeries were you primarily involved in during the pandemic?
So during the pandemic, we were involved in the usual general surgical emergencies,
Hmm.
things like pain in your abdomen, which is a very common presentation, whether there's a pandemic or not. So
Hmm.
things like having an obstruction in your intestine, what you call as bowel obstruction, appendicitis, which is one of the very common infections, infections in the colon, things like that. So these obviously continue to happen despite the pandemic. And of some of these patients did come in with super added COVID infection, so which makes the management quite tricky.
Hmm.
So my role was basically in the surgical management of patients who came to A&E, not
Right.
directly related to COVID. Although we did see a few cases of abdominal pain that was primarily from COVID infection, but obviously everyone was learning and it took time
Hmm.
to pick this up. But
Definitely.
the usual emergencies continued to come in as they normally would. In fact, because patients were worried about coming into hospital, we saw a lot of patients were coming in with delayed presentation. So we're seeing more
Right.
severe cases of what we normally commonly see. So
Okay.
appendicitis were burst. So a lot of infection, sepsis,
Okay.
just because they were worried of coming into hospital. So trying
Of
to
course.
sit at home.
Mhm.
So they came in quite late.
So what was that like for you and your surgical team to be able to deal with these cases? One, they were piling up really high, but two, you also said that of course they're more extreme because patients are more hesitant to go to the hospital when they're presenting with symptoms. So how were you able to cope under that much pressure?
So there were two things. Firstly, nobody knew
Mhm. Of
um,
course.
the risks of undertaking surgery during the pandemic. So if somebody was coming in with an emergency that needed an operation, there were various things. Do they need a COVID swab? Do they need a CT scan of their chest to identify if they've got the virus or
Mhm.
the infection of the lung with the virus? Which cases do we operate on? Which ones do we try and manage without surgery? There are
Right.
patients who come in with an emergency normally who would require major surgery and then go on to intensive care, but intensive care beds are full, or intensive
Mhm.
care was full of COVID patients. So if you had a patient who was negative, would you send them to the intensive care or not? So there were a lot of issues around this. There were constant guidances coming out from the Royal College of Surgeons
Mhm.
and various other organizations as they were learning from around the world. So yes, we were quite under pressure, not just from the volume of the cases, but also with the fact that there was this entity of unknown. Nobody
Yeah,
knew
of course,
what
it was
is the best
uncertain.
treatment for these patients.
Mhm. Well, it definitely seems like all the doctors I've been talking to so far, they've all been saying the same sorts of things. But it's amazing to see how we are still fighting this pandemic, but also how far we've come from then when we didn't know much, and now they're all able to continue and carry on. So that's really definitely very inspirational. Um, Going back to like before pre-COVID, would you say that within your specialty and within being a surgeon, are you able to strike a good work-life balance? Because of course, it must be hectic being in the operation theatre and also speaking to patients before and after surgery. Are you able to strike that balance well though?
Well, I think it's very difficult to say if any specialty, whether it's a medical specialty or not,
Mhm.
are you able to strike an absolutely good work-life balance? I think it's quite tricky to do that, especially with the medical field,
Mhm.
obviously because of the stress levels at works being so high. It is quite important to have a work-life balance, but I don't think everyone is able to achieve it to the level they want to.
Mhm.
From a surgical side, it's quite difficult to just switch off once you've come home
Of
because
course.
you've got patients on the ward who are either in need of surgery, say next week after the weekend, or patients who've just been operated midweek you're at home at the weekend, you're still wondering, how are they doing? So you're in touch with your colleagues who are on call at work saying, have you seen my patient? Any problems, any concerns? So you can't completely switch off.
Right.
So you do get texts, you do get phone calls. So it's the work-life balance is not as good as you would want it. But hey, if you're passionate about the job, I don't think you would mind it. But the key is you need to be very sure you want to do this.
Right.
And if you do that, then you'll enjoy, and you need to have a very supportive family.
Definitely. I think, from what I've heard from other doctors as well, they completely correlate with what you're saying, the idea that it is a very demanding job. But I think everyone who enters medicine really does have a passion for it. And I suppose if that sort of makes up for the fact that it can be really long hours, it can be very difficult without seeing your family for some time. But if you're dedicated, then that's all that matters. Within surgery, are you mostly in the operation theatre, or do you have other responsibilities? As we talked about the idea of communicating with patients before and after. You also mentioned clinics. Is it how much time goes into just surgery, and how much goes into other aspects of medicine?
So there is a lot of preparation for elective surgery or planned surgery. So normally I would have seen the patients at least 2 to 3 times for complex surgery.
Right.
Simple surgery, you would see them at least once in the clinic beforehand. So I do have a couple of outpatient clinics every week. One is for general surgery, one is for bariatric surgery. So you see patients pre-op. And again, in the same clinics, you also follow up patients who've had surgery before. So you don't just straight discharge them back to the GP. You would see them for a few months after surgery, make sure that everything is at a stage where you are happy with things. And then we discharge them back to the GP. So
Right.
apart from clinics and operating, I also do endoscopy. So there's a flexible camera. So pop inside the patient's throat. We look at the food pipe, stomach, and beginning of the small intestine. So I have one endoscopy list a week.
Oh, okay.
We have multidisciplinary team meetings, where we discuss cancer patients and non-cancer patients. And again, at least twice a week, you would do a ward round. So you do in the morning, you go around seeing all the patients that are admitted, both elective as well as all the emergencies.
Right.
So just operating is a very small part of a surgeon's day-to-day life. So there are lots of other aspects that go into surgery.
Right. Okay. Of course. It does seem like a very busy profession then, to be able to do all of the sort of admin work and the face-to-face contact with patients and communication, as well as the surgery. I was just wondering, with things like elective surgery under the NHS, do you feel like some types of elective surgery should be privatised to sort of save money within the NHS for other more important emergency situations?
I don't think necessarily. It's a bit of a balance between timing of surgery and the cost associated with it. So NHS is one of the world's best healthcare systems. If you look at the amount of money and effort that goes into running this service, yes, there are drawbacks. There's a bit more waiting than you would in a private sector. But when you're getting things, for free, I know you're paying the national insurance, but at the end of the day, you're not paying for every visit to the hospital. So there is that caveat that you might have to wait a bit longer because of the strain on the system. In terms of shunting some of these operations to the private sector, it happens occasionally when the waiting list crosses a particular threshold. Then sometimes patients are diverted onto the private sector,
Right.
especially now since the pandemic, because we're lagging behind on elective surgery where we hadn't performed anything for about a year.
Of course.
Now patients are being given the option of having the surgery in a private hospital, but under the NHS.
Oh, okay.
That is to try and reduce the stress on the NHS itself.
So would that be that for the patients it would still be free for them, but the NHS would be covering the costs within the private hospital?
Exactly, you're right.
Right. Okay. So in essence, the money that the NHS spends would still be the same, if not a bit more, to be able to cover the patients who aren't being able to be seen for however many years due to the wait list of the NHS, plus everything that's happened from the pandemic. So in some sense, I mean, obviously we know that the pandemic has had a huge strain on the NHS financially and emotionally on all the key workers. But it's also that all of these elective surgeries and all of these elective procedures that could have happened under the NHS within their own buildings have to now be sought out privately while still paid by the NHS.
That's true, but you have to wonder that, yes, the NHS might end up paying a bit more for doing this privately, but these patients have waited for a very long time.
Of course.
Also, some of the illnesses may mean that they present to A&E recurrently. So that means there is already a burden on the NHS in terms of workload as well as finances. So if they spend a little more money to get these particular problems sorted, even in the private sector, it would reduce the number of A&E admissions, so reduce the stress on the system anyway.
See. Makes sense. So in some sort of way, it all balances out to the same amount. I mean, if we took the idea of the pandemic aside, it does sort of balance out in the end.
Yes, I think it would.
I was wondering, what do you think is the most challenging aspects of your job? We've talked about the work-life balance and obviously the pressure during pandemic. But if before the pandemic, what would you say was the most challenging aspects?
The most challenging aspects would be to try and provide that high quality service that you want to give to your patients. Sometimes, obviously, due to various constraints, not just financial or manpower, there are various other constraints that would mean that you are not happy that you've done the best that you wanted to or you could. So achieving that phase where you have to accept that you're not able to give 100%. You have to accept or be satisfied at 98, 97, 96%. That is quite challenging. As soon as you enter the system, obviously, as you progress in your career, you do realize the limitations, and you do realize some of the ways that you can mitigate these. But it's the fact that at the end of the day, you want to be sure that you've done the best for that patient.
Of course. The idea of being a perfectionist, especially as a surgeon who's operating on the patients, I can completely understand that. Finally, I was just wondering, do you have any advice you want to give to aspiring medics like me, whether it be for medicine in general or for surgery? If there's any sort of special tips you might have or any skills that you think are very essential as part of your job?
I think the key is to be absolutely sure you want to get into this field. So first of all, in terms of doing medicine itself, you have to be aware that it's a long commitment. It's a long training process. By the time you enter the system and then come out as a consultant to be able to lead independent practice, it's many, many, many years. So it's a slow progress. So you have to be geared up for that. You have to be mentally prepared for it. Yes, the work is stressful. There'll be good days, there'll be bad days, but hey, that's possible in any specialty. If somebody is in IT, they might have busy days, they might have stressful days. But that there are lives at stake. So that adds the extra pressure. So I think if you think you're able to soak pressure, if you think you've got the skill to be able to perform under pressure, and if you have the passion to go the extra mile, then I would definitely encourage anyone to take up the field. Yes, it is hard work. Yes, there will be days when you think, oh, I should have chosen something else. But at the end of the day, when you see a happy patient, whether it's surgery or medicine, whichever field, once you've seen a patient who's treated and they are happy about it, you see a smiling family, it's very refreshing. It's very satisfying. So I think the returns and the non-monetary returns are very high in this particular field.
Great.
So you've got to be really passionate. I don't think you should enter the field because your mom wants you to, your dad wants you to, or because they have been doctors. I think you really should ask yourself, do I want to be doing this? And if so, just go for it. Once you enter it, you do need a bit of taste of different specialties. So I knew from beginning that I wanted to do some sort of surgery. Not everyone knows. So keep an open mind. See what excites you. See what you think you'll be able to excel in, and then pick that subspecialty. Every subspecialty has its own advantages, disadvantages, and as you get through the system, you will know which one you think is the best for you.
Great. That's the whole point I started this series, is just to hear about doctors from different specialities and really learn what they love about their speciality and what they're passionate about and how they entered that career. So it's been absolutely wonderful hearing from you, Dr. Ravi. Thank you so much for sparing your time today to give me this advice and to be able to discuss about your career. It's definitely been very informative.
It was my pleasure.
Great.